from the mouth to the anus and is affected and for Crohn's disease. And ulcerative colitis, it's just the large intestine, also known as the colon. So here's some pictures of IBD versus a healthy colon. So the healthy colon on the left, you can see, is pink and is wide open. Also over here on the right. Also ulcerative colitis, you can see it has some ulcerations. It's a little bit darker. Also in the right-hand side too. With Crohn's disease, that you can see it starting to stricture or close. The inflammation is, makes scar tissue and it's starting to close. There's ulcers, fissures, which are small cuts. And a lot of people have cobblestone appearance, like in England, how they have the roads in the old days, cobblestone. So the mucosal area starts to get that appearance. So IBD is not IBS, irritable bowel syndrome. They're two different things. IBD is a disease and causes destructive inflammation. IBS is a syndrome and does not cause inflammation. IBD can be seen in diagnostic imaging and has risks of colon cancer. IBS has no sign of abnormality and no risk for colon cancer. So you can see the only thing that they really have in common are diarrhea and belly pain and sometimes constipation. So inflammatory bowel disease has bloody bowel movements, bleeding or mucus from the anus, swelling, fever, weight loss, mouth sores, skin rashes, eye redness, joint pain, feeling tired, plus the diarrhea, belly pain, constipation. Irritable bowel syndrome has bloating, cramping, gas, constipation. So IBD and the American Disability Act, IBD is recognized as a disability by the American Disability Act. And it can be debilitating and sometimes lead to life-threatening complications. And people with Crohn's and ulcerative colitis, they can carry a medical disability card that gives them access to restrooms, um, like at the mall, in a store that only the employees can use. They can show them this card and say, I really need to use your restroom. That way they have immediate access. And so you can see not every disability is visible. Can you guys all hear me still? Okay, great. I keep hearing this little noise in the background. So diagnosis of IBD, many symptoms mimic IBD symptoms such as infectious colitis, ischemic colitis, drug-induced enterocolitis, solitary rectal ulcer syndrome, radiation, enterocolitis, sexually transmitted infections, divergent colitis, endometriosis, malignancy, IBS, diverticulosis disease, just regular stomach flu, gastrointestinal flu, um, you know, what is it? Food poisoning. So many symptoms mimic that. Although usually with food poisoning, it lasts a day. With IBD, it goes on. So the diagnostic goals should include determining if it's Crohn's disease or ulcerative colitis, mapping the extent of the disease, and identifying the disease behavior specifically for Crohn's disease, and recognizing the severity of the disease. So steps providers use to diagnose. So they'll use labs, getting the CBC or CRP, Stool studies, calprotectin tests show, the calprotectin test shows inflammation anywhere in the GI tract. And that gives the provider a heads up that, oh, there is something more going on. Ileocolonoscopy with biopsies, the upper endoscopy with biopsies. So with those, it can grow to Crohn's disease. You evaluate the extent of the disease with a CT or MRI scan, or sometimes X-ray. So if those come back normal, they'll sometimes do the small bowel imaging, CT and MRI. And if those are normal and the person is still having symptoms, they'll sometimes do a capsule endoscopy. And then it looks like if those come back normal or pointing to ulcerative colitis, it kind of stops there, the testing. Does anybody have any questions right now or any comments?
Not from my side.
Okay, great, thanks. So differences in diagnosing features of UC and CD. So ulcerative colitis, it mainly in the colon and the rectum. Sometimes the rectum is universally involved. Mucosal and submucosal injury, continuous pattern of inflammation, and acute onset or fast onset. So with Crohn's disease, any part of the GI tract, mouth to the anus, the rectum is involved in 10% of the cases. Transmural injury that may lead to strictures or fistulas, including preanal involvement. And then they'll have skip lesions, so it's not a continuous inflammation. And it's an insidious onset, so it just kind of creeps up on people. So what is Crohn's disease? Crohn's disease is an inflammatory bowel disease that causes chronic inflammation of the GI tract from the mouth to the anus. Crohn's disease belongs to a group of conditions known as inflammatory bowel diseases, or IBD. It is named after Dr. Burrell B. Crohn, who first described the disease in 1932, along with his colleagues, Dr. Leon Ginsberg and Dr. Gordon Oppenheimer. So Crohn's disease causes fever, fatigue, stomach pain, vomiting, weight loss, diarrhea, blood and stool, and other extraintestinal manifestations. Crohn's disease can affect any part of the GI tract from the mouth to the anus, but most commonly affects the end of the small bowel or the ileum and the beginning of the colon. It can affect the entire thickness of the bowel wall. Inflammation of the intestine can skip or leave normal areas in between patches of diseased intestine. And these are just some clinical features of CD. So the small bowel, if it's in the small bowel, and like I said, it can be anywhere, the mouth to the anus. So it can be in the small bowel, it can be in the large intestine, it can be in the stomach, or some people just have it in one area. The thing about Crohn's disease is that it moves. It can move. You might have it be diagnosed with it in the colon, and then 5 years later, it is now in your stomach. So it just can move. Inflammatory. So the small bowel, some of the symptoms of the small bowel is the abdominal pain, diarrhea, fever. If it's in the large intestine, diarrhea and blood loss, weight loss, fever, and stricturing bowel obstructions, penetrating, there's abscesses and fistulas. And here's just some percent of where it's located in people. So there's types of Crohn's disease. While symptoms of Crohn's disease can vary from person to person, the type of Crohn's you have impacts the symptoms and complications you may experience. It is important to know which part of the GI tract it's infected. So there's types of Crohn's disease or ileocolitis, where it's in the ileum and the large intestine. Ileitis, so itis is means inflammation. Um, Rachel, did you have anything to say or add?
Yeah, just with these pictures up, I was just gonna mention from my experience. I thought it was really interesting in the beginning of all this. When I was getting diagnosed, I actually had a colonoscopy, and the initial doctor only looked at the large intestine. Um, so they didn't find anything. They, diagnosed it as IBS because those symptoms are very similar. Um, and then a year went by with the Crohn's active, and the doctor finally was like, he looked back, another doctor looked back at the report and was like, he never said he followed through into the small bowel, which I think is just really important because for regular screening purposes, they normally do just look in the large intestine, um, especially if you don't have any history of irritable bowel disease in your family, which I do have history of, but they still neglected to go into that small bowel. So they ended up going into the small bowel a year later, and that's when they ended up finding it. So I just think that's like pretty interesting and really important to, if you're ever trying to rule that out, making sure that they definitely are doing that follow through into the small bowel.
Thank you. That is really important. I agree. I think that if you're going to be scoped for IBD, they need to do the upper endoscopy and the colonoscopy. And if they don't find anything and the person is still having severe symptoms or moderate symptoms or even mild symptoms, they need to do further testing. Did they do a stool test like calprotectin?
Yeah, they did, and it was out of range, but I originally, like I said, the first doctor just claimed it as IBS, and then they ended up doing imaging afterwards as well, and they could see it all through they did a CT scan and they went back and did an MRI to kind of see more details, and they could see it throughout my small intestine. And I had lost like 25 pounds over a year's period. So
Oh, that's so awful. I'm so glad that they went and investigated further.
yeah, yeah, I had some really good doctors after that I worked with.
That's so good. Well,
It
thank you
helps
for
that I was in
sharing
the
that.
field.
What's that?
It helps that I was in the field too.
Oh my gosh, yes, that's really cool. That's really cool. Thank you so much for sharing that. That's
Yeah, of
really
course.
good points. I'm sorry that you had to go through that, but
It's okay.
that's great for anybody listening that to advocate for yourself. So, again, the types of Crohn's disease. So this second one, ileitis, itis meaning inflammation. So just in the ileum. Gastroduodenal Crohn's disease is in the stomach and the first part of the small intestine called the duodenum. Did you know ileitis is in the ileum and the second part of the small intestine, which is the jejunum? And then the Crohn's granulomatous colitis, which is mainly just in the large intestine or the colon, and you can see, that it skips the red part is skipped inflammation, and perianal Crohn's, which is just in the rectum. But like I said, you can have multiple of these. You can have ileitis and perianal Crohn's. So types of Crohn's disease, there are different types of Crohn's disease. However, a person can have all or many of the types, like I said, since Crohn's disease can occur anywhere from the mouth to the anus. So ileocolitis, this is the most common form of Crohn's disease. It affects the end of the small intestine, known as a terminal ileum, and the large intestine, also called the colon. So the first part of the colon, or all of the colon. So the symptoms may include diarrhea and cramping, pain in the middle or lower right part of the abdomen, significant weight loss, intestinal strictures, which are narrowing in the intestine that makes it difficult for food to pass through. Sometimes a stricture can lead to intestinal blockages and sepsis. At least 1/3 of people with Crohn's will develop a stricture within the first 10 years of diagnosis. So ileitis, the symptoms may include the same as ileocolitis. In severe cases, complications may include fistulas, which are abnormal connections between the intestine and other organs or blood vessels, or inflammatory abscesses, which are collections of pus in a wound in the lower right quadrant of the abdomen. And just to say that fistulas and abscesses and strictures, they're not just stuck in one of these categories. They can happen anywhere in the GI tract. So the Crohn's, you can see this inflammation in this section. Let me get this laser point of the large intestine. And this part would be the ileum. So ileitis is inflammation of the ileum. So you can see this is the normal ileum. This is the appendix right here. And this is an inflamed ileum. And you can see it's starting to get inflamed and start narrowing. And this is where it's at. Gastroduodenal Crohn's disease, this type affects the stomach and the beginning of the small intestine called the duodenum. The symptoms may include nausea, vomiting, weight loss, and loss of appetite. The jejunoileitis is inflammation that occurs in areas in the upper half or second portion of the small intestine called the jejunum. The symptoms may include mild to intense abdominal pain and cramps following meals, diarrhea. Fistulas may form in severe cases or after prolonged periods of inflammation. It's hard to diagnose as the scopes do not reach there, and it's rare. It's rare to just have it in the jejunum. Crohn's granulomatous colitis. The symptoms may include diarrhea, rectal bleeding, disease around the anus, including abscesses, fistulas, and ulcers. Skin lesions and joint pains are more common in this form of Crohn's than in others. This affects only the colon, also known as the large intestine. You can see, like I had pointed out before, that it can skip areas of the large intestine, or sometimes people have it throughout their whole colon. And that you can see this poor person has, it's affecting their skin. So so the location of Crohn's and associated symptoms, we already kind of went through the symptoms. So the ileum and the colon, it's the most common form, and it's 35%. Colon only, it skipped lesions and can cause arthritis symptoms. It's more common, 32%. Small bowel only, complications may include fistulas, abscess formation, 28%, and the gastroduodenal region, it's 5%. So causes of Crohn's disease, IBD affects an estimated 3 million Americans. Unfortunately, the causes of Crohn's disease are not well yet understood. What is known is that men and women are equally likely to be affected. The disease can occur at any age, even young children, but Crohn's disease is most prevalent in adolescents and adults between the ages of 15 and 35. Unfortunately, if a person is diagnosed at a young age, the more severe it is throughout their life. Diet and stress may aggravate Crohn's disease, but do not cause the disease. Recent research suggests hereditary, genetic, and environmental factors contribute to Crohn's disease development. Crohn's disease is an autoimmune disease where your body is attacking itself. So scientists have determined that there are at least 3 causes or pathogenesis of IBD: a person's immune response to bacteria, a person's genetic susceptibility, environmental triggers in a person's life. You can see how they all go together. So Crohn's disease and the immune system. A healthy person's immune system usually attacks and kills foreign invaders like bacteria, virus, fungi, and other microorganisms. During a normal immune response, cells travel out of the blood to the intestine and produce inflammation. Under normal circumstances, harmless bacteria that present in the GI tract are protected from an immune system attack. With people with IBD, these harmless bacteria are mistaken for foreign invaders and the immune system mounts a response. The inflammation caused by the immune response does not go away. It like turns on and then it just won't turn off. This leads to a chronic inflammation, ulceration, thickening of the intestinal wall, and eventually symptoms of Crohn's disease. And it's thought too that sometimes the bacteria in the gut with people with Crohn's disease develop a biofilm. And so it's hard to reach them with antibiotics and other medications.
Does taking a probiotic help?
We're going to come to that, but there is research that there are certain probiotics that do help. There are some, it's thought, and research is still underway, but it's thought that some probiotics can actually make it worse. They work well for a while, but then they just start turning into bad bacteria, and then the cycle continues. So like lactobacillus is a good bacteria for people with IBD. Acidophilus is a good bacteria.
Thank you so much. I look forward to the rest of the information.
You bet. Thank you for your question. So genetic factors, Crohn's disease tends to run in families. So if you or close relative has the disease, your family members have an increased chance of developing Crohn's. Studies have shown that between 5% and 20% of people with IBD have a first-degree relative, such as a parent, child, or sibling, who also has one of the diseases. The genetic risk is greater with Crohn's disease than ulcerative colitis. Other genetic risk factors, the risk of Crohn's disease or ulcerative colitis is substantially higher when both parents have IBD. The disease is most common among people of Eastern European backgrounds, including Jews of European descent. There have been an increased number of cases reported in African American populations in recent years. I think Canada and Scandinavia also have high numbers of IBD patients. Environmental factors. Where you live appears to play a role in the development of Crohn's disease. Crohn's disease is more common in developed countries rather than undeveloped countries. And I don't know if that's because there's more testing than in developed countries. So people are in undeveloped countries are not being diagnosed, but maybe have the symptoms. It's also more common in urban cities and towns rather than your rural areas. Northern climates rather than southern climates have a higher development of Crohn's disease too. And it makes me wonder if it's maybe because maybe the sun or vitamin D plays a role in that. Vitamin D does a lower vitamin D has risks of higher autoimmune diseases. So, and the sun helps you produce vitamin D. Signs and symptoms of CD. So Crohn's, I know we touched on this a little bit. Crohn's disease can affect each patient differently. Crohn's is a chronic disease, which means patient will likely experience periods when the symptoms are active, known as flares, followed by periods of remission when you may not notice any symptoms at all. And you can see some of the symptoms there. You can have eye inflammation, which is like uveitis or iritis, which is dangerous for your eyes. Stomatitis, liver and bile duct inflammation, ulcers in the mouth, skin. You can have ulcers and sores, the stomach, vomiting, intestinal diarrhea, abdominal pain, cramping, ulcers in the digestive tract, fever, weight loss, decreased appetite. Like Rachel had said, she lost 25 pounds in a year. That is significant weight loss. Rectal bleeding, which can cause anemia, and sometimes people have to go get blood transfusions or iron infusions because they're bleeding so bad. And sometimes it's just not even the rectal bleeding. Sometimes the strictures can cause anemia, or there might be little pinprick sores in the small intestine that are bleeding and you don't even see the blood. That can cause anemia. Also joint pain and swelling. So GI tract inflammation, the symptoms, persistent diarrhea, rectal bleeding. The thing also, if you have a stricture or narrowing, you might have constant constipation. So not, the Crohn's disease and IBD are known as the diarrhea disease, but sometimes you can have constipation with it. It's rarer, but it does happen because you have the inflammatory response and you have strictures, which are narrowing of the intestine. So then you get constipation, which is dangerous too, because that leads to other complications.
Just-
Oh, go
Sorry,
ahead.
just to kind of touch note on that same topic, from my experience was I actually had like severe diarrhea and constipation. And I think it was after I was dealing with the severe constipation and I ended up getting a fissure and having to have surgery. That's when they finally looked further into the Crohn's disease.
Oh, that's awful. I'm so sorry to hear
No,
that.
it's
That's
okay.
awful. I know that. Yeah, if you present to the GI doctor, sometimes they may dismiss you because if you only have constipation, or they
Mhm.
won't look into IBD. Yeah. Thank you for sharing that, Rachel. I'm sorry
Yeah.
you had to go through that.
Oh no, it's okay. I'm good now.
Oh, good. Good.
I'm manageable now.
Oh, that's awesome to hear. So stomach cramps and pain, sensation of incomplete bowel evacuation. So you might have gone to the bathroom, but you still feel like you have to go more, but it just won't come out. Constipation, which can lead to bowel obstructions, anemia, malnutrition, loss of appetite, weight loss, low energy and fatigue, delayed growth and development in children, or failure to thrive in children. You can look at, there's this endoscopy pictures of a normal colon versus a colon with deep ulcerations or ulcerations in the ileum. And you can see kind of the cobblestoning, how they are, and the narrowing of it. So Crohn's disease complications. Common serious complications of Crohn's disease include fissures, fistulas, strictures, abscesses, perforated bowel, malabsorption, malnutrition, and anemia. And you can just see this normal, healthy intestine here, and the inflammation is starting to thicken it. The strictures and fistulas, which are tunnels that go into other organs. So fissures are tears in the lining of the anus or anywhere, which can cause pain and bleeding, especially during bowel movements. The treatments are ointments, medication, laxatives, surgery sometimes, and which would include an internal sphincterotomy and lateral sphincterotomy. So you can see right here, there's a longitudinal tear in the anal canal. And there's the anal sphincter. So, and here's an anal fistula. You can see this is the rectum, and there's a tunnel leading out to the skin. So fistulas, so ulcers or sores create a tunnel, which are a fistula, to a different part of the intestine, skin, or other organ. It forms when inflammation causes ulcers inside the wall of the intestine or nearby organ, and it extends through thickness of the bowel wall, creating a tunnel. Drains pus from the infected area.
And this is where we would see those perianal abscesses.
Yes, yep.
Okay.
So you can see the fistula as it's going through. So there's different types of fistulas. The most common types of fistulas in Crohn's disease patients form between two parts of the intestine, between the intestine and another organ, such as the bladder or vagina, or through to the skin surface. Women with Crohn's disease can also develop a fistula between the rectum and vagina, which may be difficult to treat. So surgical treatment depends on each individual circumstances. About 35 to 50% of adults with Crohn's disease will develop a fistula at some point. You can see there's different names. So a rectovaginal fistula is a tunnel between the vagina and the rectum, which can result in gas or stool leaking into the vagina. Repeated vaginal or urinary tract infections and pain during sex. The treatment is medication. If the fistula is infected, you may be prescribed antibiotics, and medications such as Remicade can ease inflammation and allow the fistula to begin healing. Surgery. In many cases, surgery is needed to repair a fistula. Suturing an anal fistula plug to allow natural tissue to grow over the fistula. We'll go over that a little bit. Applying a tissue graft over the fistula, repairing damaged sphincter muscles in the anus. In some cases, a patient needs a colostomy in preparation for fistula repair as well, just to give their intestines a break from digesting. And you can see this is the rectum right here. Here's the tunnel or fistula going into the vagina. Any questions on this? So enterocutaneous fistulas are fistulas from the intestine to the skin. They present as a painful bump or boil, skin abscess that is open and draining fluid or stool. A lot of times they're found on the buttocks, but you can see this person has it on their stomach. And again, here's the intestine with a fistula going up and out through the skin, and it looks like it's going this way as well. So an enteral fistula, or fistulas between the small and large intestine. Symptoms are diarrhea, passage of undigested food. You can see it's going. And here it is here. You can just see the inflammation and all the sores. Colovesical fistula, or fistulas between the intestine and the bladder. So the symptoms are burning with urination, cloudy urine or blood in the urine, stool in urine, urinary tract infections. So you can see right here, the fistula between the rectum and the vagina. This is your rectum right here. This is your bladder. And so it's in the vagina. Well, now there's a fistula from the vagina into the bladder. And that's where you can get the stool and blood coming out. You can see that here. So fistula removal, while some fistulas can be treated with antibiotics and other medications, fistulas removal surgery may be necessary if the infection doesn't respond to medication or if the fistula is severe enough to require emergency surgery. So some surgical options for fistula removal are a medical plug to close the fistula and allow it to heal, a thin surgical cord called a seton placed into the fistula to help drain any infection and allow it to heal, or opening the fistula with an incision along its length to allow it to heal, medical glue to close the fistula if it's small enough, an elastomy to give your intestines a break, and anal fistula removal. So a seton helps drain any infection and helps it to helps healing. You can see the seton is right here, and it's right here, and they put it in, and it just helps it to drain. You can see it's right there, and now it's all gone. Fistula plug. The fistula plug is made of natural biomaterial positioned from the inside of the fistula with sutures. Tissue surrounding the plug grows into the collagen, thereby closing the defect permanently. So they wouldn't take out the plug, it just dissolves. And you can see it's right here. Here's a rectovaginal plug. So the rectum's right here, and they put the plug in so it can no longer go into the vagina. And here's one that's going into the skin, the intercutaneous, from the intestine to the skin. They just plug up that fistula. So an elastomy, the patient's stool will sometimes need to be diverted from the intestine while it's healing from the fistula surgery. This is done with an elastomy, which is a procedure that brings the small intestine up through the abdominal wall so that waste can leave your body through a surgically created hole called a stoma. And then you would put a little bag on the stoma, and that's where your fecal feces would go into. And you would just empty the feces bag, everyone as needed. So the elastomy feces are collected outside your body in an ostomy pouching system. An elastomy is often used as a temporary solution to allow healing. Additional surgery to ensure the intestine is closed at the fistula location. And you can see an ileostomy is a surgical opening made on the abdomen from which the end of the small intestine is brought to the surface. You can see it right here.
Does the
And-
patient lose nutrition if that's the case?
With an ileostomy, a lot
Yeah.
of times the ileostomy and colonostomies are life-saving. You can see somebody that looks like before they've had the pouch, and they look like a concentration camp victim. And then they have the ileostomy or colonostomy, and they look like a totally different person. They are so healthy looking. So it can be life-saving. So no, I don't think that they're losing vitamins.
So
They may
if it's
need
on
to,
for a long time or something, maybe
right? They
that
may
would be
need
a
to,
concern.
with the ileostomy, it, so that's the ileum, and the ileum is where you absorb most vitamin B. So they might need to take vitamin B 12 shots. That's where you do the vitamin B, absorb the vitamin B12. So they might need to have vitamin D, weekly vitamin, I'm sorry, vitamin B12 injections, or, you know, a sublingual vitamin B12 just to get that extra. But this is a better option than suffering. So the anal fistula removal is called a fistulotomy. The primary goal is to repair the fistula without damaging the anal sphincter muscles, which are necessary for fecal continence, which is the ability to hold the fecal material in your rectum. Recurrent rates for anal fistulas are low after surgery. Complications are rare, and there is typically little impact on fecal continence. During the fistulotomy, a cut will be made at the site of the fistula. The fistula is opened surgically to remove the infected area with pus or other fluids. In many cases, stitches are used during a fistulotomy. If stitches aren't used, the wound would be left open and either packed or covered with gauze to heal. So strictures is another complication of Crohn's disease. And strictures are narrowing of a section of intestine caused by scarring. May lead to an intestinal blockage. After repeated cycles of continued inflammation and healing in the lining of the intestine, scar tissue can replace the normal cells. As a result, the scar tissue may result in narrowing of the GI tract. Occasionally, this narrowing can get so severe that it can cause a bowel obstruction. The most common locations for these strictures are the ileum and the ileocecal valve, which is the entrance from the small to the large intestines. And it's also in the upper GI tract, colon, rectum, or anus. You can see the normal intestine and the intestine with the stricture. I mean, bowel cannot move through that. And that's where the constipation comes from. So depending on where the stricture is located, patients with strictures can have blockage symptoms that include nausea and vomiting, severe abdominal pain, constipation, abdominal bloating, inability to pass gas and stool, weight loss, and anemia. You can see this where it's really inflamed and there's a stricture. And there's a real life picture, probably a X-ray or CT scan or MRI. So strictures may lead to bowel obstructions, which are very painful and life-threatening, may burst and cause sepsis, and the patient needs to get the emergency medical care immediately. You can see right there, it's a bowel, the point of the obstructions, and it's just backing up. and then pretty soon it just bursts. And so the vomiting may turn and have a fecal or poo smell, the abdominal distension or bloating, constipation with failure to pass gas. And so the bowel sounds, there's high-pitched at first bowel sounds where it just is a really high-pitched squeak, and then pretty soon your bowels are just silent. So diagnosis and treatment: to diagnose strictures, colonoscopy and CT scans or MRIs of the abdomen can be used. So there's the treatment, medication, and or surgery. So there's a strictureplasty is a surgical procedure to repair a stricture by widening the narrowed area without removing any portion of your intestine. A small bowel resection. A bowel resection is a surgical procedure to remove a portion of the small or large intestine that has been damaged by Crohn's disease. Ileocecal resection. This procedure removes diseased tissue at the end of the small intestine, an area called the terminal ileum, which is often severely affected by Crohn's disease. This surgery is often required for patients with a stricture, fistula, or abscess in the terminal ileum. A large bowel resection. This surgery is like the small bowel resection, except it's performed to remove diseased portions of your large intestine, commonly referred to as a colon, but includes both the colon and the rectum. So diagnosing and treatment. So strictures, to treat strictures, abscess, fistulas, etc., there are medical options if there is also a significant amount of inflammation, and surgical options, especially if strictures reoccur frequently. It is important to repair strictures because a narrowing of the intestine could lead to a blockage that prevents stool from passing through the body. When strictures are caused by disease, inflammation, initial treatment may typically include medication to help improve the narrowing of the intestine. And if that doesn't work, surgery would be a necessary option. So a strictureplasty to repair the stricture is a generally safe procedure. It is most effective in the lower sections of the small intestine called the ileum and the jejunum. Strictureplasty is less effective in the upper section of the small intestine called the duodenum. Strictureplasty avoids the need to remove a section of your small intestine. It is preferred when possible because removing portions of your small intestine can sometimes cause other complications, including a condition called short bowel syndrome, or SBS, which occurs when large sections of the small intestines are removed due to surgery or various surgeries, and the body is unable to absorb adequate amounts of water or nutrients. So you can see the surgical repair of this stricture. An incision is performed in the area affected by the stricture, and then a new opening is folded and sewn back together. The final result is a slightly shorter intestine, but there is no loss of intestinal tissue, and nutrition absorption is not affected. A small bowel resection is a surgical procedure to remove a portion of the small or large intestine that has been damaged by Crohn's. During the surgery, the diseased section of the intestine is removed and the two healthy ends are joined together. And sometimes the person has to, before they can even do this, they have to try, they might have to go further back because the disease portion is so big, so that they have to cut back into the healthy tissue and put healthy tissue together. So it might be a little bit bigger. So the ileocecal resection removes diseased tissue at the end of the small intestine called the terminal ileum, and it's often severely affected by Crohn's disease. This surgery is often required for patients with a stricture, fistula, abscess in the terminal ileum. During an ileocecal resection, the end of the small intestine and the start of the colon, called the cecum, are removed. Your appendix may also be removed during this surgery as it's attached to the cecum. The healthy end of the small intestine is then reattached to the colon. And in the ileocecal resection, there's also a sphincter in the cecum that goes from the small intestine to the large intestine. So that's also removed. And that may cause complications called SIBO, or small intestine bacterial overgrowth, because you don't have that that valve that lets bacteria out of the small intestine. So it's just going back and forth without it. Short bowel syndrome, SBS, is a possible complication of multiple small bowel resection. The small intestine absorbs necessary nutrients from digested food into the bloodstream, which provides nourishment for the rest of your body. If too much of the small intestine is removed, short bowel syndrome can develop and cause nutritional deficiencies or even malnutrition. Other complications of short bowel syndrome can include kidney stones, electrolyte imbalance, bacterial overgrowth in the intestine, malabsorption of medication, and acidosis, a condition caused by too much acid buildup in the body. I know I read there was a patient who had short bowel syndrome, really, really bad, and she had to have a what is it, surgery to replace her bowels. I forget what that's called. So symptoms of SBS are chronic diarrhea, weight loss, stomach pain and cramping, bloating, heartburn, gas or flatulence, oily and or smelling stool, weakness and fatigue, bacterial infections, food sensitivities. So large bowel resection, the surgery is like the small bowel resection, except it's performed to remove diseased portions of the large intestine. As with the small bowel resection, Crohn's disease reoccurs about half the time after a large bowel resection, usually at the site where the intestine was connected. So an abscess is another complication of Crohn's disease. And they're a collection of pus which can develop in the abdomen, pelvis, or around the anal area. Abscesses require antibiotics to treat the infection, but your doctor may also recommend surgical drainage of the pus cavity to ensure the area heals completely. Symptoms of an abscess: severe pain in the abdomen, painful bowel movements, discharge of pus from the anus, lump at the edge of the anus that is swollen, red and tender, and fever. You can see there's the picture.
Deborah, we have a question
Okay.
from the chat section. Jenny's asking why wouldn't we use a stent?
A stent for the abscess? Sometimes I think that maybe the abscess, they usually try to drain it, surgically drain the pus, and then to ensure that it heals completely. You don't want to plug, or they might do the stent on some abscesses. I'm not sure about that. Maybe the area is too infected to put a stent, and that just might cause a more of a complication.
And for the stricture, could a stent be used?
No, strictures are then so narrowed. No, they try to do the strictoplasty for that, or they might have to like do a resection of the bowel
Got
just
it.
because the stricture is so small. You know, it's cutting off your bowels.
Gotcha. Thank you.
You
And do
bet.
you want to, is there a time coming up where it might be a good time for a break?
I think now would be a good
Is it
time.
time? Okay.
Yeah. Yeah, I mean, let me cover the treatment for
slide.
that,
Okay,
the
great.
abscess, and then we could take the break.
Perfect.
So the treatment is abscess draining. The surgeon will make a small cut into the abscess and insert a thin tube to drain the pus. The tube may be left in for a week or more to allow the abscess to completely drain and begin healing. Most people feel better within a few days of the surgery. You can see that. Okay, so we could take a break.
Mhm.
Okay,
Take a 10-minute break or so, come back at 10:10.
sounds good.
Okay, great.
Thanks.
To those perianal abscesses. And when we get that bowel smell, then we would send them to the follow up with that with a general surgeon. Would that be an instance where they should actually follow up with gastro, or?
It depends. I would almost think that they would need to follow up with the GI. But if they're being told to see the general surgeon, then I think the general surgeon can take care of it as well.
Okay.
I mean, they might want to follow up after the surgery just to see why they got it, if there was anything else going on, if there's further testing. going on for the cause of it.
All right, that makes sense.
I would probably say like follow up with both, only because the GI doesn't do those surgeries, so they would refer you to surgery anyways.
Right. Right. Okay. So is everybody, but thank you for your question. That was a really good one. Carrie, is everybody back? Should I start? Okay, so another complication of Crohn's disease is a perforated bowel. So the chronic inflammation of the intestine can weaken the bowel wall to such an extent that a hole develops. A small bowel resection surgery may be required if a perforation or a hole develops in the wall of the small intestine. So perforations can cause a serious infection and must be treated immediately. It can be life-threatening. If your GI tract is perforated, the contents may spill into your abdomen and cause peritonitis and infection. Such an infection can lead to sepsis, sometimes incorrectly called blood poisoning. Sepsis is the body's often deadly response to infection. Sepsis kills and disables millions and requires early suspicion and treatment for survival. So the symptoms of a perforated bowel are severe stomach pain, chills, nausea, fever, vomiting. It's life-threatening. A perforation anywhere in the GI tract is a medical emergency. They use it to diagnose it, use of x-rays and or CT scans, blood tests. Sepsis must be treated quickly with antibiotics, surgery, and fluids. So you can see the hole and this green stuff is the fluids and solids from the bowel, which accumulate in the lower abdomen. The rupture site is right here. And gas escapes from the bowel and rises to accumulate under the diaphragm. So you can see the gases going up into the diaphragm up here. So perforated bowel treatment, surgery is one option. Usually they will give you antibiotics, of course, probably an IV with antibiotics, but then they need to go in and fix the hole. So the surgeon must perform a colostomy or ileostomy. This surgery allows the contents of your intestine to empty into a bag through a stoma. A hole is created in the abdomen. And we covered that earlier. So that allows the rest of the intestines to heal. Then a second surgery, so the surgeon can reattach their intestines, so there's no longer need to eliminate the waste through the stoma. In other cases, the surgery may be permanent and the second surgery is not needed. In addition to surgery to repair the perforation, the patient will likely receive IV antibiotics to prevent other infections. You can see this is part of the surgery. Here's the green fluid and solids from the hole. They're just repairing it. And then there's the colostomy. They're detaching that. So another complication or symptom is malabsorption syndrome and malnutrition. Due to impaired GI tract, food nutrients are no longer effectively absorbed into the gastrointestinal tract. This leads to malnutrition and anemia and can be life-threatening. Symptoms are weight loss, failure to thrive in children, diarrhea, stomach pain and distension, fatigue, vitamin and mineral deficiency, loss of muscle mass, anemia, edema or swelling, bleeding tendencies, and osteomalcia. The treatments are enteral nutrition, exclusive or partial, which is a formula drink they can drink or through tube feedings. And parental nutrition is nutrition through the bloodstream where they bypass the gut altogether. So treatments, enteral nutrition, also called EN, liquids. The liquids contain all the proteins, carbohydrates, fats, minerals, and vitamins necessary to sustain you. And it helps improve or protect your small intestine's ability to absorb nutrients. So you can drink enteral nutrition, or it can be ingested through a feeding tube. And the types of food are the nasogastric tube or NG tube. This is what this picture of this boy has. It's so a lot of times it's in the nighttime when they're sleeping. If you can either do partial or complete EN nutrition, and the formula, you put it in this little bag and it just goes down the tube and through the nose, and the tube is down into the stomach. The patient would probably put this NG tube in their nose every night. It's placed in one of your nostrils and travels down to your stomach. A nasoduodenal tube or an ND tube or a nasojejunal tube or an NJ tube is placed through one of your nostrils down into the portions of your small intestine. Gastrostomy tube or G tube or jejunostomy tube or J tube is put directly into your stomach or intestine through a surgical incision into your skin. So with that, that would probably be complete EN. You probably wouldn't eat anything. It would just go directly into your stomach. You'd have to have a surgery for that. So, and then parental nutrition or PN delivers nutrients and calories directly into the bloodstream through a catheter inserted into a large vein. So reasons to use is the person needs bowel rest due to extremely severely flare, a bowel perforation, or a fistula. And so you would need to probably get have a surgery for this, so it can be permanently there, or temporarily permanent. So you don't have to do it every night. And before they do the surgery, the person's nutrition needs to improve. Another reason for the parental or PN is the patient has short bowel syndrome. So extraintestinal manifestations. So symptoms beyond the intestine are redness or pain in the eyes, vision changes, uveitis, iritis, and you can see over here, this person has some uveitis going on. There's mouth sores, all these ulcers in the mouth, swollen and painful joints, skin rash or skin complications such as bumps, sores, rashes, pyoderma gangrenosum, erythema nodosum, fever, loss of appetite, weight loss, fatigue, night sweats, loss of normal menstrual cycle, osteoporosis, arthritis, kidney stones, kidney problems, rare liver complications, including PSC and cirrhosis of the liver. You can see, and sometimes the back is, the spine is affected as well. Diagnosing and testing. Crohn's disease has a wide range of symptoms that can vary from person to person. There is no single test to confirm Crohn's disease, and Crohn's disease symptoms are often like other conditions, including bacterial infections. The healthcare provider should evaluate the patient's current medical history and use information from diagnostic testing to exclude other potential causes of their symptoms. Some of the diagnostic tests include lab tests, endoscopic procedures, imaging procedures, and biopsies. And this is pretty much the same for ulcerative colitis. So diagnosing and testing, the lab tests, they would check for anemia or infections. So blood tests to check for anemia. And anemia is a condition where there aren't enough blood cells to carry adequate oxygen to tissues, or to check for signs of infection from bacteria or viruses sometimes. And then stool tests, test for hidden blood or occult or organisms such as parasites in the patient's stools. So sometimes a person may have parasites and they might think that they have Crohn's disease, but right now they only have parasites, which it's not only, but they have parasites. So another way to test is endoscopic procedures, or a EGD, also named upper endoscopy, and where they're looking at the esophagus, the stomach, and the duodenum. You can see where the tube goes down. It has a little light, and it goes, here's a video that the provider would watch as it goes down in from the mouth to the esophagus, to the stomach, and then to the duodenum. In this procedure, the doctor uses a slender, flexible, lighted tube to examine the esophagus, stomach, and first part of the small intestine. And usually there's on this scope or tube, there's the provider can take little biopsies. Here's some pictures of the scopes. And what the provider would be seeing, this is the end of it, which would have the light going out of it and just traveling down the intestine and esophagus. So endoscopic procedure, along with the upper scopes that I know that Rachel had mentioned, that at first she only had the colonoscopy, but then they went and did the upper endoscopy and got the final diagnosis. So colonoscopy allows the doctor to view the entire colon using a thin, flexible, lighted tube with a camera at the end. During the procedure, the doctor can also take small samples of tissue or biopsy for laboratory analysis. A biopsy is the way to make the diagnosis of IBD versus other forms of inflammation, mainly because it has that cobblestoning, but not everybody has the cobblestoning, but that is another way. Plus the scope can show strictures, and it can show, the ulcers as well. A flexible sigmoidoscopy, the doctor uses a slender, flexible, lighted tube to examine the rectum and sigmoid, the last portion of the colon. If the colon is severely inflamed, the doctor may perform the test instead of a full colonoscopy. So you can see the sigmoidoscopy just goes from here down, and then the colonoscopy just does the whole colonoscopy. And they go through the rectum with the tube and up.
Actually, just to follow on that, I actually didn't have an upper endoscopy. They just did a colonoscopy, but the first one they didn't follow through into the first portion of the small intestine. So that's where they found it. But the upper endoscopies are always good too.
Okay. Thanks for clarifying that. Okay, so diagnosing and testing. Another way is the capsule endoscopy. This test is sometimes used to help diagnose Crohn's disease involving your small intestine, especially the jejunum, as the scopes don't go there. The patient must swallow a capsule that has a camera in it. The images are transmitted to a recorder you wear on your belt for 8 hours, after which the capsule exits the body painlessly in your stool. The patient may still need an endoscopy with a biopsy to confirm a diagnosis of Crohn's disease. Capsule endoscopy should not be performed if there is a bowel obstruction because it might get stuck and then they'd have to go in and do surgery and remove the capsule. You can see he's swallowing it and he wears this little recorder for probably about 8 hours. And then you don't have to retrieve the capsule out of your stool. You can just flush it because it's all recorded in this. And you take it back to the provider. There's also a balloon-assisted enteroscopy. For this test, a scope is used in conjunction with a device called an overtube or balloon. This enables a doctor to look further into the small bowels where standard endoscopes don't reach. This technique is useful when a capsule endoscopy shows abnormalities, but the diagnosis is still in question. You can see it's just like that, but it has a little balloon on the end of it, which stretches the intestine so it can go into the small intestine. So imaging procedures are X-rays, CTs, and MRIs. So with X-rays with severe symptoms, the doctor may use a standard X-ray of the patient's abdominal area to rule out serious complications, such as a perforated colon. A CT scan is a special X-ray technique that provides more detail than a standard X-ray does. This test looks at the entire bowel as well as tissues outside the bowel. CT is a special intergraphy is a special CT scan that provides better images of the small bowel. And this test has replaced barium X-rays in many medical centers, but barium X-rays still are used in some medical centers. And magnetic resonance imaging, or an MRI, is a scanner that uses magnetic fields and radio waves instead of X-rays or radiation to create detailed images of organs and tissues. An MRI is particularly useful for evaluating a fistula around the anal area, or a pelvic MRI, or the small intestine, an MRI intergraphy. Unlike CT, a CT scan, there is no radiation exposure with the MRI, which is good for Crohn's because they'll probably have multiple imaging procedures throughout their life. And so you don't want to build up that radiation with multiple CT scans or X-rays. You can see kind of like with this banana, the MRI, what it shows with the banana with the MRI scan and a CT scan. And here's the X-ray. So imaging procedures, the barium X-ray. A barium X-ray is a radiographic X-ray examination of the gastrointestinal GI tract. Barium X-rays, also called upper and lower GI series, are used to diagnose abnormalities of the GI tract, such as tumors, ulcers, and other inflammatory conditions, polyps, hernias, and strictures. And with this stuff, the patient has to drink a big cup of chalky white barium. And this is hard for most patients with Crohn's disease as they don't feel good in the first place. And then having to drink a huge cup of chalky white barium is really unappetizing and hard to do for them. So it's good that this other imaging is starting to be used more than these upper and lower GI series. Also with diagnosing and testing, biopsies are taken. A biopsy may be taken from the GI tract while a colonoscopy or endoscopy is performed. During the biopsy, a small piece of tissue is removed from the inside of the intestine for further testing and analysis. Your biopsy tissue will be analyzed in a pathology laboratory and screened for disease. So biopsies are also used for many things, including colorectal cancer screenings. And you can see here, this shows the cobblestoning of the Crohn's, and it's also called granulomatous Inflammation or cobblestoning of the inside lining of the GI tract is considered the hallmark of microscopic diagnosis in Crohn's disease. But granulomas can be detected in only about 21 to 60% of CD patients. So if they find that, then that's like the gold standard. But there's also like the inflammation and the other symptoms we talked about. So Crohn's disease versus ulcerative colitis. Crohn's disease and ulcerative colitis share similar symptoms, and they are both types of inflammatory bowel disease, but they are not the same illness, and they affect different areas of the GI tract. So Crohn's disease, like I had said, can affect any part of the GI tract from the mouth to the anus and can affect the entire thickness of the bowel wall. Ulcerative colitis, only the colon and rectum are affected, and it affects the innermost lining of the small intestine. So they wouldn't get the perforations, they wouldn't get the fistulas. So you can see CD versus UC. The age of onset is similar. The symptoms are similar. But for Crohn's, it depends on the location of the disease. With the symptoms of ulcerative colitis may include stool urgency, fatigue, increased bowel movements, mucus in the stool, nocturnal bowel movement where you have to get up at night, it wakes you up and you have to go to the bathroom, and stomach pain. So it's very common in UC to have bloody stools. In Crohn's disease, it's variable. Not everybody has it. Some people has it. And malnutrition is very common in Crohn's disease, and malnutrition is less common in ulcerative colitis. So what is ulcerative colitis? Or UC is a chronic disease of the large intestine in which the lining of the colon becomes inflamed and develop tiny stores, open sores or ulcers. This condition is the result of the immune system's overactive response. Ulcerative colitis is a chronic inflammatory bowel of the large intestine that affects the lining of the colon and causes small sores or ulcers to form. These ulcers produce pus and mucus, which cause abdominal pain and the need to frequently empty your colon. So, like I said, it affects only the large intestine or colon, and the predominant symptoms are rectal bleeding, frequent small volume loose stools, mucus discharge from the rectum, tinnitus, urgency, rectal pain, abdomen, and stomach pain. You can see here, that's diverticulosis, but ulcerative colitis, you can see the ulcers. There are different types of UC that can affect different parts of the colon and rectum. There is a wide array of symptoms and complications depending on the extent of the disease and the type of UC the patient has. So there's proctitis, which affects only the rectum. There's left-sided colitis, which affects the left side or the descending colon and the sigmoid colon. Then there's the extensive or pancolitis, which affects the whole colon and the rectum. Types of UC, the ulcerative proctitis. In ulcerative proctitis, bowel inflammation is limited to the rectum. This condition typically affects less than 6 inches of the rectum, and it is not associated with an increase of cancer. The symptoms may include rectal bleeding, so you'd have a bright red blood, rectal pain, urgency in your bowel movement. The left-sided colitis is continuous inflammation, begins at the rectum and extends as far into the bend of near the spleen. Left-sided colitis also affects rectum and lower segment of colon located right above the rectum, known as the sigmoid colon. And like with ulcerative colitis, the inflammation is continuous, whereas Crohn's, if this part of the colon was diseased, you would have spots of it. Symptoms may include loss of appetite, weight loss, bloody diarrhea, pain on the left side of the abdomen. Types of UC, extensive pancolitis affects the entire colon. Continuous inflammation begins at the rectum and extends beyond the splenic fixture. So that's where the last one stops. Well, this one continues all the way through. Symptoms may include loss of appetite, bloody diarrhea, stomach pain, and weight loss. So very similar symptoms. So the symptoms of ulcerative colitis vary from person to person, and about half of all UC patients experience mild symptoms, which are loose and urgent bowel movements, bloody stools, stomach cramps and pain, persistent diarrhea accompanied by abdominal pain and blood in the stool. And when I talk about stomach cramps, I don't mean the stomach, I mean the abdominal. Ulcerative colitis is an unpredictable disease, and the length of periods of remission between flares can make it difficult for doctors to evaluate whether the course of their treatment has been effective or not. Here's some other symptoms, kind of like Crohn's disease. You have the fatigue, the irritated and red eyes, fever, mouth ulcers, weight loss, reoccurring diarrhea, needing to empty the bowels, rectal bleeding, rectal mucus, areas of red and painful and swollen skin, painful joints, swollen joints. So symptoms beyond the intestine, there are several symptoms of ulcerative colitis that can affect general health and quality of life, which are loss of appetite, weight loss, nausea, fever, low energy and fatigue, anemia, low red blood cell count, delayed growth and development in children. You can see kind of how this one has ulcers. Yeah, this one doesn't. Causes of UC, just like Crohn's, genetic predisposition, the genes a person has inherited, plus their immune system, or an abnormal reaction of the immune systems, which is the body's protection system against harmful substances. So the body's reaction of the immune system to certain bacteria in the intestine, like I said, it turns on and then it doesn't turn off. Plus environmental triggers, probably triggered by something in the environment. So, just like Crohn's. So UC diagnosing and testing. The tests used to diagnose UC are similar to Crohn's test. And diagnosis is based on several factors, including the medical history, a physical exam, and a series of medical tests, which are laboratory tests of blood and fecal matter, stool specimens, is mainly the same as Crohn's. X-rays, MRIs, and CT scans, endoscopies, a sigmoidoscopy, and a total colonoscopy, biopsies of the colon. So IBD treatment. So this is for Crohn's and ulcerative colitis. There is no standard treatment that will work for all patients. Each patient's situation is different and treatment must be followed for each circumstance. Treatment for Crohn's disease and UC can include the use of medication, surgical procedures to repair or remove affected portion of the GI tract, and alterations in diet and nutrition. So goals of the treatment for IBD patients are turning off that inflammation. So induction of the remission so that the patient feels well. They want a normalization of labs, growth, development, and nutrition. A maintenance of remission. So they just want to maintain that remission. Stable disease control and optimization of therapy. No steroids. They might prescribe steroids in the beginning just to get the patient out of the flare, but they don't want the patient on long-term steroids. Prevent, so that would mean they would need to use other medications. So maintenance of remission, prevention of relapse over time, changing the natural course of the disease. So if they're severe, they want to change that and make it and just put them in remission. So then they, for treatment, they would keep monitoring the disease and prevent the disease from coming back. So would monitor for early relapse, monitoring therapies, prevention of infection, and cancer prevention. Any questions? Okay, so IBD medications, there are a lot of medications for IBD, which is nice because I think probably 30 years ago, there were minimal medication treatments for IBD. So let's see. So the medical treatment for Crohn's disease and UC have two main goals, which we talked about: achieving remission, control or resolution of inflammation leading to symptom resolution, and then maintaining remission. Medication treating IBD is designed to suppress the patient's immune system's abnormal inflammatory response that is causing their symptoms. Suppressing inflammation not only offers relief from common symptoms like fever, diarrhea, and pain, it also allows intestinal tissue to heal. In addition to controlling and suppressing symptoms, including remission, a medication can also be used to decrease the frequency of symptom flare-ups. With proper treatment over time, periods of remissions can be extended and periods of symptom flare-ups can be reduced. Several types of medications are being used to treat IBD disease today. There are several groups of drugs used to treat IBD. Some of these options are used to get your symptoms under control, which is known as inducing remission. Medical therapy, also called maintaining remission or maintenance, is used to decrease the frequency of Crohn's disease. So step-up treatments for IBD medication therapy is stepped up according to severity at presentation with the provider or failure to reach remission with the prior step or medication. So the disease severity, so mild, so the provider would probably start the patient off on aminosalicylates, antibiotics, topical corticosteroids. If the patient didn't respond to this, they might throw in these, or if the patient presents as moderate, the provider might start off with the immunomodulators and oral corticosteroids. Immunomodulators, I mean. And then a severe presentation, or if these still do not work, the provider might step up, or the patient might need to go on biologic medications, or they might have surgery. And over here, there's a list of some of the medications under each title. So aminosalicylates are 5-ASA These include medications that contain 5-aminosalicylic acid. They work topically in the body in areas of diseased GI mucosa, and they can work to decrease inflammation in the lining of the GI tract. And here are some of the names. So Pentasa. A lot of the 5-ASA, some of them are used for UC, like this Roesa and Canasa. They can also have this where it's like a foam or a cream and they put it rectally. These ones like Pentasa are pills. 5-ASA are thought to be effective in treating mild to moderate episodes of IBD and are useful as a maintenance treatment in preventing relapses of the disease. They work best in the colon and are not particularly effective if the disease is limited to the small intestine. Here are some examples. Pentasa is pretty much the only one that covers all the intestine and the colon. Corticosteroids are man-made drugs that closely resemble cortisol, or hormone that your adrenal glands produce naturally. They suppress the immune system and are used to treat moderate to severely active Crohn's disease. These drugs work non-specifically, meaning that they suppress the entire immune system rather than targeting specific parts of the immune system that cause inflammation. Corticosteroids have significant short and long-term side effects and should not be used as a maintenance medication. If you cannot come off steroids without suffering a relapse of your symptoms, the doctor may need to prescribe other medications to help manage the disease. So examples, these medications are available orally and rectally. So prednisone, methylprednisolone, which are given usually in the IV, hydrocortisone, budesonide. Corticosteroids are powerful and fast-acting anti-inflammatory drugs that have been frequently used in the treatment of acute flare-ups of IBD. So you can see some of the side effects of them. You have hypertension or high blood pressure, your blood pressure goes up, glaucoma, cataracts, especially if you're on it long term, cushingoid symptoms or moon face, osteoporosis, increased risk of infection or impaired wound healing, where you're growing hair in different parts, like on your face if you're a woman, weight gain, increased appetite, emotional disturbances, mood swings, depression, might get angry easily, infections, your vitamin D or vitamin K might drop, GI upsets, peripheral edema or swelling, and insomnia. And this is with the chronic use.
I've seen a lot of patients have elevated blood sugars as well,
Oh, really? On the corticosteroids?
and specifically prednisone.
Oh, really? Oh, okay, that's interesting. So another medication are antibiotics and may be used to treat bacterial infections in the GI tract. Infection in Crohn's disease can include abscesses and fistulas around the anal canal and vagina. And examples are ampicillin, ciprofloxacin, metronidazole. Antibiotics are frequently used as a primary treatment approach, primarily in Crohn's disease and with complications in IBD. Immunomodulators. This class of medication modulates or suppresses the body's immune system response so it cannot use ongoing inflammation, cannot cause it. They take several months to begin working, are generally used when 5-ASA and corticosteroids haven't been effective or have been only partially effective. So this is more for moderate disease. These and they can also be used with severe in combination with another medication. These medications may be useful in reducing or eliminating the need for corticosteroids and in maintaining remission in people who haven't responded to other medications given for this purpose. So examples are azathioprine, which is also called Imuran, tacrolimus, cyclosporine, and the 6-mercaptopurine, which I probably totally did not pronounce correctly. Immunomodulators weaken or modulate the activity of the immune system and are medications often used to treat people with IBD. They are immune suppressants since IBD is an autoimmune disease. The patient immune system is overreacting and attacking itself. So for severe and sometimes moderate and as a maintenance, biologic therapies. These medications are the latest class of therapy for people with Crohn's disease and who have not responded well to conventional therapies. Biologics are antibodies grown in the laboratory that stop certain proteins in the body from causing inflammation. Biologic therapies offer a distinct advantage in IBD treatment because their mechanisms or action are more precisely targeted to the factors responsible for IBD. So it's like a pinpoint target. Instead of affecting the whole body, they're pinpoint. Unlike corticosteroids, which affect the whole body and may produce major side effects, biologic agents act more selectively. These therapies are targeted to proteins that have already been proven to be involved in IBD. So IBD medications, the biological therapy, the anti-tumor necrosis factor agents, also called anti-TNF, biologics known as anti-tumor necrosis factor agents bind and block a small protein called tumor necrosis factor alpha, or TNF alpha, that promotes inflammation in the intestine as well as other organs and tissues. All anti-TNF medications have been shown not only to reduce the symptoms of IBD, but also result in healing of the inflamed intestine. While anti-TNF medications are not effective for every individual, many patients benefit from this class of medication. It may take up to 8 weeks after starting an anti-TNF to notice an improvement in symptoms, though many experience more immediate improvement. In anti-TNF medications include Humira, Remicade, Cimza, and sometimes people might have a side effect and not be able to take one of those, and like their blood pressure might drop, they might get a weird rash. So then the provider would try them on a different one. So another biological therapy, integrin receptor antagonists. These biologics prevent the cells that cause inflammation from moving out of blood vessels and into tissues by blocking a protein on the surface of those cells. Examples of this type of medication includes Tysabria and Entyvio. And another biological is interleukin 12 and 23 antagonists. This biologic targets specific proteins, which are the interleukin 23 and interleukin 12, that play a key role in the inflammation process. An example of this medication is Stelara. You guys might have seen commercials on these biologics as well. So biologics are antibodies grown in the laboratory that stop specific proteins in the body from causing inflammation. Their mechanism of action are more precisely targeted to the factors responsible for IBD. So biosimilar therapies are nearly identical copies of the biological therapies. They have the same effectiveness and safety as the biological therapy. Given the complexity of drug design, biosimilars cannot be exact copies of biologic therapy, but still contain the same active ingredient, mechanism of action, and dosing. So some key points are biosimilars are just as safe and effective as the original. There are no clinical meaningful differences. So they're almost like generic forms. Biosimilars are taken in the same form, injection or intravenous, and dose as this related biological medication, also known as the reference product. Biosimilars may be identified by the naming structure in which the name of the reference product is listed, followed by a hyphen and 4 additional letters. So for the infliximab, which is Remicade, they would include this DYYB and name it Inflectra, and so on. So biologics can cost up to $100,000 annually. I know a person who had to get on Remicade, and this was probably about 5 years ago, and it was $12,000 a month. So pretty high price, which the biosimilars would be just as effective, but at a way lower cost. So some biologic risk and special considerations. While the benefit often far outweighs the risk of biologic medications in patients suffering from IBD, patients should considering the following when using them: the side effects and intolerance. Because biologics are given by intravenous infusion or subcutaneous injections, they may produce redness, itching, bruising, pain, or swelling at the injection site. Other side effects may include headache, fever, chills, hives, and other rashes. Other occasionally severe reactions may occur, like your blood pressure dropping. Infections. Because biologics affect the immune system to help control by IBD, biologics can impact your ability to fight infections. Further, anti-TNF medication increase the risk of developing less common or atypical infections. Like somebody who might be taking Humira for IBD, it might trigger a psoriasis. While most patients using biologics never experience an infection related to these medications, it's important to discuss this with the IBD specialist. And before they start, they need to be tested for TB and hepatitis B. And they should get their yearly flu vaccines, pneumonia vaccines, all the vaccines that they need. So biological cancer risk, anti-TNF medications have been associated with a small but measurable increase in the risk of lymphoma, which is an uncommon cancer. While the overall risk of lymphoma is very small, the risk is highest in patients using anti-TNF medications in combination with another immunosuppressant, such as Imuran. They might cause liver problems. Biologic therapies have been rarely associated with changes in liver function. If the patient develops jaundice, yellowing of skin and eyes while using biologics, they need to inform their doctor immediately. Arthritis, while anti-TNF medications often are effective treatments for inflammatory arthritis, in some situations they may cause new joint pain in people with IBD. Lupus-like reactions. Rarely, an anti-TNF medication can cause lupus reaction-like reactions, which may present with symptoms such as a rash, joint pain, muscle ache, and/or fever. And usually it stops when stopping the anti-TNF. Nervous system occurrences, on rare occasions, nervous system disorders such as numbness, weakness, tingling, or visual disturbances have been reported while using the anti-TNF. So while medication is often the first treatment option, really quick, does anybody have any questions with this? Okay, so IBD surgery. Medication is often the first treatment option. Many people with IBD eventually require surgery. Some patients may choose to have surgery to improve their quality of life, and may, for others, surgery is a life-saving necessity due to medical complications of IBD. So primary goals for surgery is to conserve as much bowel as possible, alleviate the disease complications, help patient achieve the best quality of life. And Crohn's note, even though a person may have surgery which takes out the affected area, Crohn's disease can and usually does come back. And here are some ideas of when to consider surgery. So IBD surgery, there are several types of surgery for Crohn's disease, depending on the location of the disease in the GI tract and the complication the patient is suffering. So strictureplasty, we talked about, it's the treatment to fix the stricturing of the bowels. Proctocolectomy and colectomy, the colon and or rectum may need to be removed in some patients with extensive disease or complications. Fistula removal, which is to treat fistulas, and we talked about that already. Small and large bowel resections to treat fistulas, stricturing perforation, and we talked about that as well. And we also talked about abscess draining to treat an abscess in the abdomen, pelvis, or anal area. You would use the abscess draining. Ostomy surgery is a procedure that allows stool to pass through a surgical created opening in the body, a stoma to discharge bodily waste, and we touched on that a little bit as well. So the proctocolectomy is a surgical removal of the colon and rectum. If your colon and rectum, together known as the large intestine, are diseased and must be removed. There are variants of this procedure, but patients with Crohn's disease are generally recommended for a proctocolectomy with endoilostomy. In an endoilostomy, the end of the small intestine is inverted through a small hole made in the abdominal wall or stoma to divert waste into an ostomy bag. So one thing to note, if a person with UC has their colon and rectum removed, they're considered cured because that is mainly where their disease is. Let's see. So this is where the colon, picture of the colon and rectum are removed. The end of the ileum for the, if they were gonna do an ileostomy, then they would take that end of the ileum and put it through the bowel wall and then attach the bag or the stoma or the ostomy bag. The proctocolectomy is the surgical removal of the colon and rectum. If your colon and rectum are diseased, it must be removed. So patients with UC may have the option to undergo a proctocolectomy with ileo pouch anal anastomosis, which creates an internal J pouch using the end of the small intestine and eliminates the need to permanently wear an ostomy bag. That procedure, however, is generally not recommended for patients with Crohn's disease because the disease frequently occurs in the internal pouch. So for UC, they take out the small intestine and the colon and just leave just a small, like the anal sphincters. And then they attach, they make a J with the end of the ileum. And then they open that little portion up and attach it to the sphincters. And then the patient who had UC can just pass their bowels, pass their feces through just their ileum. And then they don't need the pouch. So a colectomy is a surgical removal of the colon if the colon is diseased and must be entirely removed, but the rectum is unaffected by IBD. Once the colon is removed, the surgeon will join the ileum or the lower part of the small intestine to the rectum. A colectomy allows the patient to continue to pass stool through their anus without the need for an external pouch. You can see that the rectum is preserved and the ileum is connected to the rectum. So the ostomy surgery is a procedure that allows stool to pass through a surgically created opening in the body or stoma to discharge bodily waste. Your stoma is a part of the bowel or smaller large intestine that pokes out of the abdominal wall and provides an opening for waste to pass out. The waste is then collected from your stoma into an external ostomy pouch or a bag, which is an appliance which is adhered to the abdomen on the outside of the body. You can see. There are two common types of ostomies for IBD patient named for the part of the intestine that is open. An ileostomy is an opening from the part of the small intestine called the ileum, and a colostomy is an opening from the part of the large intestine. Your ostomy may or may not be permanent, but recovery from surgery will be similar. And ostomy surgery can be life-saving and make a huge difference in a person's life. And I know we talked about that, but you can see this person, I mean, he looks really malnourished, and with the ostomy, this has really has changed his life. And I think, you know, with social media, a lot of people who have ostomies, they're trying to just make it normal. And so you'll see, you know, these beautiful young women or handsome young men and older people, you know, posing, you know, maybe in a bikini or, you know, and just showing off their bag, which is they're just trying to normalize it and make it part of their life, which is great. So IBD alternative complementary treatments, there's diets, the specific carbohydrate diet, also known as SCD, paleo, keto. There's therapies like acupuncture, probiotics, herbal and dietary supplementation. So diets can be helpful in managing your IBD during flares and periods of remission. While several specialized diets may be helpful for some IBD patients, no one plan has been researched enough to prevent or control IBD, with the exception of that enteral nutrition, which is delivered in that nutrient-rich formula that we talked about earlier. Specialized IBD diets are often debated in the medical community because they don't work in every case and can be restrictive, which may lead to weight loss or malnutrition. The best diet is the one that meets your individual nutritional needs and helps you manage your IBD symptoms. So the specific carbohydrate diet is this diet, also known as SCD. These diet plan limit or exclude grains, fiber, and certain sugars. They allow the allowed carbohydrates are monosaccharides or one-celled sugars, which have, you know, and have a single molecule structure that allowed them to be easily absorbed by the intestinal wall. Complex carbohydrates, which are disaccharides, are double molecular sugars, and polysaccharides, chain molecules, are not allowed. complex carbohydrates that are not easily digested. They believe that these carbohydrates that are not easily digested feed harmful bacteria in the intestines, causing them to overgrow, producing byproducts and inflaming the intestinal wall. The diet works by starving out these bad bacteria and restoring the balance of bacteria in the gut using probiotics as well. The allowed foods are mainly those that early man ate before agriculture began. The diets we evolved to eat over millions of years was predominantly one of meat, fish, eggs, vegetables, nuts, low sugar fruits. Our modern diet, including starches, grains, pasta, legumes, and breads, have only been consumed for about 10,000 years. In the last 100 years, the increase of complex sugars and chemical additives in the diets have led to huge increase in health problems, ranging from severe bowel disorders to obesity and brain function disorders. So for Crohn's patients, there have been studies like the one at Rush University, and other universities and medical clinics are starting to look at it. For Crohn's patients, SCD appears to improve symptoms and quality of life, according to a new study published in the Gastroenterology magazine, which I forget what I was going to say, but we'll move on. Another one is paleo, which is similar to SCD, but it's a little bit less restrictive, and it includes lean meats, fish, fruits, vegetables, nuts, and seeds, and it eliminates grains. And it also just says about, we're eating, the paleo is based on what the hunter and gatherer ate before agriculture came. The ketogenic diet is a high-fat, adequate protein, low carbohydrate diet that in medicine is used mainly to treat hard to control epilepsy in children. The diet forces the body to burn fats rather than carbohydrates. There's also gluten-free. This diet cuts out gluten, a protein found in wheat, barley, and rye food. Some IBD patients have found that a gluten-free diet reduces their symptoms. I've read that about 80 to 90% of people with IBD actually have a gluten-free intolerance. There's also low FODMAP, which is an acronym for fermentable oligomonosaccharides and polyols. It is a diet that cuts back on groups of sugars that can be poorly absorbed by your GI tract. And then the Mediterranean diet is rich in fiber and plant-based foods, including olive oil, low-fat dairy, herbs, and spices. And this has also been shown to help people with Crohn's disease. There are some supplements that some IBD patients do and are currently under investigation by research that may provide additional benefits for IBD patients. Those are omega-3 fatty acids, curcumin, probiotics, prebiotics, fecal microbiota transplant. So omega-3 fatty acids found in fish oils are known to have anti-inflammatory properties and several other health benefits. You can see a lot of what they do. Supplements: curcumin, naturally occurring chemical found in the spice turmeric, which is derived from a ginger root and may help to reduce inflammation. Probiotics are live organisms which, when consumed in adequate amounts, confer health and benefit to the host, used to restore the balance of these good bacteria in the body. They are generally safe with few potential side effects, such as gas or bloating, but the studies are limited. There's also prebiotics, are a form of fiber that is found in food for the they are food for the probiotics. They support healthy gut bacteria, may boost the immune system, improve digestion. Fecal microbiota transplant is a procedure in which fecal material is transferred from a healthy individual or a donor to a patient with alteration in normal microbiota. which is the recipient. Although it is effective for the treatment of recurrent C. diff bacterial infections, further research is needed to determine if it is an effective treatment for IBD. And these are all treatments people with IBD, some people are doing and may or may not have seen improvement in their symptoms. Medical cannabis. In small studies, smoking cannabis or marijuana, the dried parts of the cannabis plant, has improved IBD symptoms, including pain, nausea, and decreased appetite. However, there's currently no evidence that medical cannabis can reduce IBD inflammation or improve disease activity. Further research is needed and underway now regarding the impact of cannabis on IBD. Cannabis is composed of over 70 active compounds called phytocannabinoids or cannabinoids. The first is THC. THC is most known for its effects on one's mental state. It has been known to elevate nausea and chronic pain and improve one's appetite. So even some cancer patients use medical cannabis and they say it really helps them. The second is CBD, which is part of cannabis, which has more anti-inflammatory or immune properties. Therapeutic uses may include reducing inflammation and treating insomnia, sleep apnea, spasticity, and pain. And with IBD, sleep is an overlooked treatment as well. Sleep is vitally needed. A good night's rest really helps in reducing stress. And here's some experimental evidence suggests that endocannabinoids, molecules found in the body that closely resemble compounds found in the cannabis plant, may play a role in limiting intestinal inflammation and decreasing intestinal motility. However, there's conflicting evidence regarding changes to the expression of endocannabinoid receptors in patients with IBD. Another therapy is acupuncture, and it's one of the oldest therapies of traditional Chinese medicine dating back more than 3,000 years. The principle of acupuncture is stimulation of different points, in part important for the normal functions of the body. These points are called acupoints, which are actually bundles of nerve cells and are located along the lines connecting different organs. You can see the stomach meridian. They might point the needles in those points. So research is going on to assess the benefits of acupuncture beyond pain management. Some studies relevant to IBD reported that acupuncture improved GI symptoms, including abdominal pain, diarrhea, constipation, gas, bloating, and nausea, as well as alleviating inflammation. Several studies demonstrated the effectiveness of acupuncture for IBD, both in human clinical trials and in the experimental models of IBD. So the roles of the medical assistant in assisting a patient with IBD. So would work, so they would usually work in the specialty field of gastroenterology. Gastroenterology is the area of medicine that focuses on the health of the digestive system or the gastrointestinal tract. These are the digestive organs found from mouth to anus, including the stomach and intestine. Medical assistants support gastroenterologists in various clinical and administrative duties, such as the following. So the administrative duties would be communications with patients, including schedule patients' appointments, maintain medical records, schedule laboratory tests and collect reports, schedule surgeries, work on prior authorizations, refill prescriptions, manage billing and payment, process insurance claim, take inventory, and let the suppliers of the medical suppliers know. So for the clinical and medical duties, take vital signs, prepare patients for procedures, conduct basic laboratory tests, prepare the examination room and equipment, assist the doctor in administering medications, diagnostic testing and treatments, assist in phlebotomy, sterilize and disinfect scopes, as well as other tools, And one of the most important is be empathetic and caring. So that concludes our discussion on inflammatory bowel disease. Does anybody have any questions or comments?
I think this information's been very helpful. I just started working with a general surgeon in May, so thank you so much.
Oh, I'm glad to hear. Great to know. You bet. You're welcome.
And I'll say, just like with my history of working in GI, like it was definitely pretty on the administrative side, because the endoscopy center was separate. But if any like MAs are ever looking for like kind of an administrative position, gastroenterology was definitely like a good route or experience for me, at least on the administrative side, because I got a lot of experience with triaging and prior authorizations and really just like being the main point of communication for the patient. So it was really rewarding.
That's good to know. I'm sure that the administrative side probably keeps a person really busy in the GI, because there's probably so many referrals and prior auths that are needed for all the different treatments and diagnosing procedures that are needed.
Oh yeah, you definitely stayed busy. It was just a different type of busy than like the clinical side.
Right, yes. And probably a lot of medication refills. And
Yes.
did you do the clinical side as well?
So because the endoscopy center is completely separate, usually it's nurses in the endoscopy side, or even like patient care techs. But so it was complete different like office for us. But I was just on the office side where like the patients were being seen in office, and then we were scheduling and taking care of like all their procedures and imaging, like arranging all of that for them.
Okay, cool.
Yeah.
Thank you for letting, contributing. That's really nice to know.
Yeah, it was a fun field. I enjoyed it. Thank you.
So any other questions or comments?
Anyone?
Can you do another class on like diverticulitis?
Yeah, Deborah, can you?
Sure.
That would be
Yeah.
amazing.
Yep. Yeah, I'm sure some of the tests are pretty similar when diagnosing diverticulitis as IBD tests.
Great. Well, we'll definitely start working on our spring offerings. So we're going to try to offer at least 3 in the spring, hopefully. So we'll definitely be in touch as soon as the busy holiday season is over. And I will be sending certificates to everybody in the next couple of days. So certificates of attendance will be coming soon. And I will submit the roster in the next couple of days also. So they're a little bit more timely at the AAMA as far as getting the continuing ed credits uploaded into your record. So they seem to be caught up. So you should see that soon. Anybody have any questions for me?
So this is the last continuing education units for this year.
For this year. Yeah, it's a little bit hard in November and December to get anything organized, and attendance is usually pretty low too.
Deborah was very detailed. Thank you so
It was
much.
very good. Absolutely.
Thank
Thank
you.
you.
Good to see you, Claudia.
So good to see you too.
Yeah, sometimes it's like a little reunion.
It is.
It is. Yeah, I'm sorry I wasn't with the video much. I'm coughing and I'm not feeling so well, and I didn't want you guys to see me coughing all the time.
I hope you feel better.
Yes.
I have to, yes. At least it's negative COVID test, which is good.
Oh, good.
That is good.
Yeah.
Well, you all take care of you, stay healthy, and I hope I will hear from everyone soon.
Definitely. I
You
hope you all
too,
have a great
Claudia.
weekend. I did record it. If you have any coworkers that might need a continuing ed, these are all recorded. So, and the AAMA will accept a recording. So just for future reference, if you happen to miss one, don't worry, I record it.
Oh,
And
that's
always get
great to
credit.
know.
Yeah.
Maybe
Yeah.
I can talk to you about that.
Okay. Yeah. So some people are like, oh my gosh, I have to renew soon. So yeah.
Oh, yeah,
Yes.
Carrie, would we just email you then? Because I know I was sick during the last one I meant to be on.
Mhm.
So would we just email you which
Yep.
one we need? Okay, that would
Yeah,
be
and I'm
awesome.
in the process of setting up somebody mentioned setting up a YouTube channel. Not familiar with that at all, but I thought if I set up a YouTube channel, I can upload these videos and they can be accessed at your convenience. You don't have to wait for me to replay them. So I'm working on that. So it is accessible.
Oh, awesome.
Yeah.
That's great.
Did I miss any other continuing educations? The ones I had, it was at the beginning of the year, those 3 in a row. Did you have any other?
We had one, it was on campus, it was on suicide prevention.
Yeah,
That one was hard for people to come to. It was limited space and you had to be there. So, but that's
So
the only other one.
That one wasn't recorded.
No,
Okay.
a lot of personal stories in there and
Oh,
yeah, and
How
some people it
awful.
hit pretty hard. So
yeah.
great. All right. Well, fantastic. Deborah, thank you so much. And thank you all for coming. And I'll see you next time. If I don't get to wish you well, happy holidays, happy new year. And I'll be in touch in January sometime.
And
Wonderful.
Carrie, I'll email you.
Wonderful. Anybody missing anything, just send me an email.
Okay.
Okay.
Great. Thank you so
All right,
much.
thank you guys.
Thank you.
Okay.
Thank you. Great presentation.
Thank you. Bye-bye.
Bye-bye.
Bye.